All right, well, we're at 7:30, so good morning and welcome to Geriatric Grand Rounds, everybody. A few announcements before we get started. Our next Grand Rounds is going to be December 3rd. Our speaker is going to be Jody Waterhouse, who's the director of the Multidisciplinary Center on Aging, and she's going to give us an update on all the things that she's been doing at the new Multidisciplinary Center on Aging, so please join for that. Our next Journal Club will be December 10th. And our presenters for that will be Drs. Chris Azelby and Dr. Sarah Teets. Following today's Grand Rounds, you will receive an email with a link to a recording of today's presentation and a copy of the slides. Also included will be a link to an online evaluation, so if you'd please take a couple minutes to fill that out, we'd really appreciate that. For questions during the presentation, go ahead and submit those in the chat or the Q&A box at any time, and we can go ahead and we'll have time for questions and answers at the end of the presentation. Put those in as we go along. So I'm very pleased to introduce our speaker today, Dr. Jennifer Stevens-Lapsley. Dr. Stevens-Lapsley is a professor and director of the Rehab Science PhD program in physical therapy at the CU Anschutz Medical Campus. She's also a health scientist at the Eastern Colorado VA. She has nearly 20 years of clinical research experience in older adult patient populations. Her research ranges from mechanisms of skeletal muscle dysfunction to the implementation of best rehab practices in the post-acute care setting. Her clinical research has resulted in more than 150 publications, numerous awards, national and international speaking invitations. Over the past decade, she's received more than $14 million to support her clinical research. So we're just thrilled to have her here with us this morning talking about getting old is not for the weak. So welcome, Jen, and we'll turn it over to you.
Thank you very much, Carrie, and it's a pleasure to be here today, albeit from a distance instead of in person. But thank you for joining me today. I'm going to start out by doing something that Wendy probably wouldn't want me to do. Acknowledge her tremendous award as a distinguished professor. So this award is the highest recognition that can be bestowed on a University of Colorado faculty member. And individuals have to have a record of distinguished performance and research, in aggregate, a record of excellence and promotion of learning and student attainment of knowledge and skills, and a record of outstanding service to the profession and to CU. And Wendy joins a cohort of only 118 faculty members since 1977 who have been granted this honorary designation. So anyone who's worked with Wendy knows that she's incredibly deserving of this award. She's been absolutely instrumental in helping build the foundation for much of the work that I'm going to share with you today, along with the Division of Geriatrics and Bob Schwartz. But she has been absolutely instrumental in many of our research careers and just supporting many of the research efforts here at the University of Colorado. So it is a great pleasure to see her achieve this tremendous honor. So I wanted to start out with that, and I'm sure there'll be a celebration down the road, but given our current circumstances, we're going to have to probably put a hold on any major types of celebration, but more to follow. So I'm going to talk today about medical deconditioning in older adults and how it impairs functional mobility and increases hospital risk, and talk about ways that walking speed, something as simple as walking speed, can help you determine which patients might need different types of services, additional rehab or alternatives. And I'm going to talk about the barriers to practice and what we need to do to overcome some of those barriers. And I'm also going to spend some time, for those of you who may or may not be familiar with the concepts of high intensity resistance training incorporated into rehabilitation, how we can really use the evidence that we're developing to shape the future of care for our older adult populations. And so starting out, just providing a couple of really not surprising, but sometimes shocking statistics, depending on what setting you're working in. But during a hospitalization, older adults spend 83% of their time in bed and 12% of their time in a chair. And if you do the math, that doesn't leave a whole lot of time left for getting up and about, for mobility. 68% of patients are discharged from the hospital below pre-hospitalization levels of function. And hospitalized older adults are 61 times more likely to develop a disability compared to those who are not hospitalized. And older adults with medical deconditioning have higher rates of readmission and lower rates of discharge to the community. And so that sets the stage for the picture that I'm going to paint today. And that is focused on the fact that function is increasingly linked to rehospitalizations and a number of adverse events. And so over and over again, we see reports of physical function being one of the best predictors of things like rehospitalization. So you can measure smoking status, you can measure use of assisted device, you can measure any number of comorbidities, but if you take functional status by itself, it is one of the best predictors of hospitalization. And we can see that here. We see that when you look at this is the percentage of individuals who are readmitted to the hospital. Using a functional independence measure, we're able to assess kind of what an individual's functional mobility looks like. And when you see the individuals in red here, the patients who score the worst on this particular outcome, they have the highest risk for readmission. And the patients who score the highest have the lowest risk for readmission. And so over and over again, the literature supports this. We see that when you look at pre-admission activities of daily living, so how functional people were before they were admitted to the hospital, we see a pattern where as you go down from no impairments to dependency in ADLs of greater than 3, you see that the odds ratio increases. The likelihood of an individual being at increased risk of hospital readmission increases in proportion to what their capabilities were before hospitalization. These are data from our group showing, gathered from patients at innovAge, so all-inclusive care for the elderly, a PACE program, showing that the short physical performance battery, which is a test, if you're not familiar with it, that consists of a sit-to-stand activity 5 times, a gait speed assessment, and a balance assessment. It's very quick and easy to perform, and it allows us to get a lot of information on mobility and function. And what you see here is that if individuals have an SPPB score of greater than 8, their risk for hospitalization is much less than individuals who have an SPPB score of 0 to 3. And obviously, to some degree, this is intuitive, but the data show us over and over again that this is the pattern that we see. So at the beginning of COVID, I thought this was a rather humorous depiction of physical activity and what was happening in our community. So some individuals, if you had pets, you might have taken them for an excessive number of walks early in March, right, when we first had to transition to working from home. Other individuals, myself included, saw a dramatic drop in our physical activity. Managing kids at home and trying to restructure and reorganize things had a tremendous impact on the overall levels of physical activity many of us were able to engage in. And so physical activity is obviously another big predictor of things like hospitalization. And so what's happening in our older adults? What types of declines have we seen as a result of COVID related to physical activity that puts individuals at risk for adverse events? And like hospitalization. And what we see is that there are in the literature, many articles related to COVID starting to describe patterns of physical activity in older adults. The impact of home quarantine has had a detrimental effect, obviously, on physical activity. And many older adults just express challenges figuring out how they can exercise safely without being at risk of exposure in the community. And so older adults were definitely deemed to be at one of the highest risk categories during this pandemic, both in terms of COVID itself, but then also reductions in physical activity. And when we look at the literature, we see that indeed, before and after COVID, we see declines in physical activity across all ages, young to older, over 60. And you can see on the left here, the top graph, you can see that this is showing kind of the declines in vigorous, moderate, and total physical activity. And something as simple as walking, we saw a pretty substantial decline in total physical activity. And you can see in older adults, there's about depending on the article, depending on the reports, there's about a 30 to sometimes 40% decline in physical activity as a result of COVID. And so when we look at the impacts and the implications of this, we obviously see that the isolation is resulting in decreased physical activity, which increases sedentary behavior, which leads to sarcopenia, frailty, and other signs of declines in physical function and overall health, which then puts people at increased risk for COVID-19 related complications. So it's a little bit of a vicious cycle and a concern, healthcare concern for all of our older adult populations or patients. And so let's take a case. It's a very simple case. 70-year-old male with multiple comorbidities, including low back pain, diabetes, hypertension, who has a gait speed in your clinic a year ago of 0.9 meters per second and comes in today with a current gait speed of 0.7 meters per second. And I'm hoping by the end of this presentation, if you're not familiar with kind of where those metrics fall in terms of normal gait speed, you will be. And you'll have an appreciation for whether or not this individual has experienced a significant decline in gait speed. So I want you to think about that individual and whether or not you would be concerned and whether or not you would want to refer that individual for additional services such as rehabilitation. So I'm going to describe to you how gait speed can be used in a clinical capacity, not only to predict how long you're going to live, but also to use it as a tool to determine which patients need what types of services. So these results were pulled from 9 participating studies that included 35,000 older adults. Excuse me. When you look at this graph here, what you see, or the depiction here, is different categories of fall risk. So when you look across the literature, each one of these is a particular publication that's shown to determine what someone's fall risk is and what their risk for hospitalization or death is. And what you see is a pattern. Individuals in the green zone are independent with activities of daily living. So they're the ones that are able to perform, light yard work, carry groceries, do household activities. Whereas individuals in the yellow zone are individuals who are at risk for hospitalization and falls. These are individuals that are often in assisted living facilities. In some cases, they have significant assistance at home to help them with some of their personal care. And they often have early signs of cognitive decline. Individuals that are in the red zone are individuals that are often in long-term care facilities or require extensive additional assistance in order to accomplish their activities of daily living. And so what you're going to see is that when we break this down, the red zone ends up being individuals that are 0.6 meters per second or less, and the green and above zone is going to be 1.0 meters per second, leaving the yellow zone to be 0.6 to 1.0 meters per second. So I'll break that down for you in just a minute further. But just to give you a feel for someone who's walking 0.7 meters per second. So this is equivalent to the case that I shared with you, or the case that I mentioned a minute ago. This is what someone 0.7 meters per second looks like when they're walking. So hopefully that gives you just a little bit of a grounding in terms of talking about gait speed. You can picture kind of patients or participants in research studies that you've interacted with that might walk at 0.7 meters per second. And remember that 0.7 meters per second is right in the middle of that danger zone, that yellow zone, that runs from about 0.6 all the way up to 1.0 meters per second. So I'm going to describe in just a little bit more detail. Some of you may have seen this before because it is very compelling. But this, out of that pool of 35,000 individuals that were studied, or almost 35,000 individuals, This is a description of how many, the gait speed at baseline from those individuals was able to predict how long individuals lived. So when we look at individuals in the red zone, which are less than 0.6 meters per second, and then we look at individuals in the yellow zone, which again are 0.6 to 1.0 meters per second, and we compare those to individuals in the green zone, which are over 1.0 meters per second, what we see is a striking pattern. Now, if we take those subgroups and we look at how many of those individuals were alive, oops, I don't know why it's repeating it here. How many of those individuals were alive at 3,000 days? So 3,000 days after the baseline assessment of their gait speed is 8.5 years later. And when we look at the percentage of each of these that are alive, when we look at the stratification by gait speed, we see that 55 to 60% of individuals were alive at 8.5 years if they started out in the red zone. That's below the 0.6 meters per second. And 70 to 82% were alive if they started out in the green zone. The yellow zone. And 90 to 95% were still alive if they started out in the green zone. Highly predictive of mortality. Now, when we take a look at men who are 65 and above and their median survival, and we look at their gait speed at baseline, so starting out with a 70-year-old male as an example, who walks 1.0 meters per second at baseline, these data are able to extrapolate, if we take the red line back, that that individual is going to live 14 additional years. When we look at this 70-year-old who now starts out at 1.4 meters per second, and we do the same thing, and we extrapolate backwards, we see that that individual is going to live an additional 20 years. Obviously, there's a margin of error in these predictions, but it is striking how well gait speed is able to predict something like mortality. Even more importantly, how much can we change gait speed and how does that influence mortality? So let's take a look at individuals who are tested over the course of a year, quarterly, multiple times, and individuals who had a 0.1, these are older adults, who had a 0.1 meters per second improvement in gait speed at 1 year are shown in green. Individuals who had a transient improvement in gait speed are shown in yellow. That means they had an improvement, but then they had a decline, and at the end of the year, there really wasn't a whole lot of change. There was a net gain of 0. And then we take individuals who are in the red who never improved their gait speed. So whatever they started with, they didn't improve from baseline. And what we see is that 9 years later, those baseline change, or the baseline gait speed and the change over that 1 year period of time predicted mortality 9 years later. So 70% of the individuals who were in the green zone, who changed, in this case, improved, were alive, whereas only 60% of those that had a transient improvement were alive, and 50% that never improved were alive. So this is really important because it shows that gait speed is not only an important predictor of mortality, but it's a modifiable risk factor. And we can intervene on it. We can improve gait speed, we can improve physical function, and we can extend the lives of our patients. I won't go into a lot of detail here, but what this illustrates is a number of, there's a lot of support for a 0.1 meter per second difference in gait speed being meaningful. There's lots of literature saying that 0.1 indicates poor health status, a change of 0.1, poor physical function, more disability. So that's the target. When you see individuals drop in their gait speed more than 0.1 meters per second, that signals the need for an additional look at what's contributing to that decline in gait speed. Similarly, improvements of 0.1 meters per second are related to improved health status, fewer hospitalizations, and reduce costs in terms of about $1,000 per 0.1 meters per second improvement. So that 0.1 meters per second is an important target to keep in the back of your minds. And so my group and others have spent time really trying to promote gait speed as the next vital sign. We've been working with our VA to try and introduce the idea of measuring gait speed at every visit. If you could measure gait speed and document it in the medical record, just like you do other vital signs, you would have a measure that you could evaluate over time and intervene appropriately when you see declines. And so it's a modifiable risk factor like body temperature, pulse rate, respiratory rate, blood pressure. So it's not hard to measure. Stopwatch, marking out a course on the floor is enough to easily assess and document gait speed in our older adult populations. So this just kind of breaks things down. I mean, how can you take this back? Those of you who are working in clinical settings with older adults, how can you take gait speed back to your clinics tomorrow and implement and integrate it into your workflows and practices? So it's like I said, it's a feasible and easy measure to assess. You want to identify individuals that are either below 0.6 meters per second. That's that threshold where you go from that yellow to red zone, or greater than 1.0 meters per second. And to give you a little bit more additional context, most individuals in a skilled nursing facility start below, in a short-term stay, below 0.6 meters per second and are discharged just slightly above 0.6 meters per second, so somewhere around 0.7. There's obviously, or 0.8, there's obviously a range, but just to give you kind of a sense. And that's why I often describe that kind of yellow zone as people who are in assisted living or have substantial assistance at home until they're able to recover their function enough to be closer to that 1.0 meters per second target, the independent target. So then obviously educating patients regarding gait speed. A family member of mine was visiting and comes to visit once a year. And I noticed that her gait speed had declined substantially. And so I pulled out my charts and references and showed her kind of the implications. And now, granted, I wouldn't necessarily do that with just any patient. I might try a more general approach to educating. But wouldn't you know it, next year when she came back, she was walking a whole lot faster. So there's something about just kind of empowering individuals to understand the value of gait speed as a predictor of mortality that can be very effective. And obviously referring patients to rehab and continuing to monitor. Because gait speed allows us to measure systemic changes and cumulative effects of multiple system processes, we're often able to see an important decline as a result of multiple system components before those individual components become apparent. And so as far as referrals, I've kind of described, if you're greater than 1.0 meters per second, you're probably fine, you're at low risk. You could refer patients to a program like Silver Sneakers. Obviously, gyms are not in widespread utilization right now, or a program like GeroFit, which does have a tele-rehab program at the VA, or tele component at the VA, tele-exercise component. You could, if they're 0.6 to 1.0 meters per second, or if they're greater than 1.0 meters per second, they have pain, then they're at moderate risk, and they would benefit potentially from a referral to rehab or fall prevention clinic. And if they're less than 0.6 meters per second, they're at very high risk and really require some additional attention and referral in order to keep them out of the hospital and minimize additional potential for adverse events. So there's really an opportunity, as I mentioned, for rehabilitation to play a critical role in getting individuals back on their feet and recovering and restoring function, especially during our COVID-19 pandemic, trying to get people back to where they were by improving and increasing their levels of physical function. But there are a number of barriers that make it difficult for us to optimize physical function. And I'm going to run through these quickly, but just kind of describing why aren't we seeing higher levels of physical function aside from the COVID-19 pandemic issues. And one of the central reasons is we have a really big emphasis on this reimbursement-based practice as opposed to evidence-based practice. And acute care, we see this. We see faster discharges, although we've seen a little bit of a kind of more of a moderation of time to discharge, at least certainly prior to COVID, so that patients aren't readmitted back to the hospital. But because of the penalties, we definitely saw a little bit of movement in that direction. But more recently, what we've seen is in skilled nursing facilities, we used to see that the average length of stay was 25 days. And with the majority of individuals being discharged around day 21 or 21. And we used to have therapy measured by minutes of therapy, these RUG levels. Not necessarily on the intensity of the actual intervention, but intensity was kind of dosed in terms of minutes of therapy. And this often resulted in low intensity therapy. There wasn't the incentive to provide high intensity therapy because individuals were paid in terms of minutes. But in October, about a year ago, there was a change in skilled nursing facilities, PDPM, and therapy visits were no longer determined by minutes of therapy, or the reimbursement was no longer determined by minutes of therapy or the number of visits. And so our evidence that I'm going to share with you that higher intensity intervention is safe and more effective suddenly became of greater interest to skilled nursing facilities, because now the goal was to discharge people faster and provide the most effective rehabilitation and care that we could in skilled nursing facilities. So the data and the evidence that I'm going to share with you now aligns a little bit better with reimbursement. In home health, many of you may be familiar with PDGM. So there were changes in home health such that reimbursements were also no longer tied just to the number of therapy visits. And this led to therapy utilization that decreased. Now, obviously COVID influenced this as well, but in January and February, we saw a dramatic decline in home health utilization even before COVID was on our radar. And so we saw, again, a change in needing more, we needed to provide higher quality intervention in a shorter period of time, both in the skilled nursing facility setting and the home health setting, which again aligns with what I'm going to share with you as far as evidence. The other barrier to maximizing physical function has been this lack of incentives for transitional care. And there's been a lot of people looking at this, and there's certainly been a lot of improvements in this area over the past decade, even in the past 5 years. And probably, accountable care organizations do a better job of this because there's more incentive for them to follow individuals through the transitions from hospitalization to skilled nursing facility to home health. But we do consistently see that in some cases, home health therapists really don't have that discharge information. And so they're starting from scratch in terms of reproducing and recreating a picture of who this patient is in front of them and what their needs are. The good news is I've seen a dramatic improvement in the transfer of information over the past 5 years, which is very promising in terms of really aligning with patient-centered care and really providing optimal care for many of our older adult populations. The other big one is the fear of litigation. So, when it comes to mobility and maximizing physical function, the practice of negative defensive medicine is pervasive. So mobility is often avoided by nursing and CNAs because it's perceived as an unnecessary fall risk. Many have said, I don't want to fall on my shift, right? And that's true because the reality is that falls are more quantifiable and they're more closely tied to financial penalties. And so an individual practitioner is more likely to be accused of fault than muscle atrophy resulting in deconditioning. So you're not going to get sued typically because someone sat in their chair for too long, but you could get sued because someone fell. And so changing us to be more comfortable with increasing mobility in these older adult populations and providing evidence that they are not at greater risk for falls with the right precautions and the right safeguards. And so that's what we've been working to develop is more guidelines to help guide individuals, practitioners to be more confident in increasing mobility in a variety of different settings. So the next barrier for implementation of optimal practice patterns to improve physical function is the current emphasis on returning people to their prior level of function. And so if someone's hospitalized and they experience a decline in physical function, this threshold of independence is really important. Because once you fall below that threshold of independence, that's the threshold at which you're no longer able to say, get out of a chair independently, and you need other people to help you. And when that happens, your mobility decreases precipitously. Makes sense. If you can get out of a chair on your own to get paper or get whatever it is that you're looking and needing to get, you're more likely to be more mobile. But as soon as you're dependent on other people for every type of activity, like getting out of a chair, getting out of bed, toileting, dressing, then you lose a lot of that mobility. The sheer volume of what you're able to do throughout the day often declines. And so what we've promoted is the concept of not only getting back to that pre-hospitalization level of function, but hopefully exceeding it. Because a lot of times that's the target. Once we're back there, that's good. Or sometimes we don't even get back there with common practice. And yet that pre-hospitalization level of function might have been one of the reasons that an individual ended up in the hospital. They had very little functional reserve, and that contributed to hospitalization. And so trying to increase the bar, trying to get people better, to give them a little bit of a buffer and protect them from a significant decline that results in that dependence, that falling below that threshold of independence. The last major category that I'm going to talk about is the lack of awareness of more effective clinical strategies. So when we think about dosage of exercise, safe dosage of exercise for medically complex patients is important. High intensity is possible, and I'm going to share with you some information that supports that, but it's often perceived as unsafe. And so I'm going to go into a little bit more detail there. And one of the things that I often describe is, well, let me share this with you first. Choosing Wisely is an initiative across multiple medical disciplines where individuals have put together the top 5 things that need to change in a profession. In the physical therapy profession, don't prescribe underdose strength training programs for older adults is on that list of top 5. Instead, match the frequency, intensity, and duration of exercise to the individual's abilities and goals. It's on the list of top 5 because it's pervasive that we see this underdosing of strength training programs. When we look at the nursing literature, we see a similar pattern, right? That nursing says, don't let older adults lay in bed or only get up to a chair during their hospital stay. We need greater mobility. We need greater levels of physical activity. So it's recognized what we should be doing, but it's not consistently applied. And across the country, across a variety of settings, whether it's outpatient, whether it's home therapy, whether it's skilled nursing facility setting, whether it's an acute care setting, by and large, when we've gone into facilities and documented what they are doing from a rehab perspective, most individuals are receiving these general conditioning activities. So stepping, walking, getting out of bed, general conditioning activities. Some emphasis on motor control, some emphasis on aerobic training, and then at the very top of this pyramid, the least used element of rehabilitation in many of our older adult populations, so our frail, medically complex, is resistance training. This was a survey we did of home health practice across the country. And 27% of home health therapists use some form of resistance exercise. But the resistance they're using is in the form of yellow TheraBand, red TheraBand, or green, which are the lowest levels of TheraBand. These are the elastic band that you often see used in exercise. And when we ask how many pounds, if they're using weights, individuals are using 1 to 2 pounds of resistance or even less. And so the question I always ask therapists to think about is if you put a 2-pound ankle weight on someone's ankle and do a knee extension exercise, is that providing the same resistance, the same forces that are necessary to hypertrophy muscle that getting out of a chair would for someone who's 6 foot and weighs 300 pounds? Absolutely not. The physics and the forces that are transferred by that 2-pound ankle weight for that knee extension exercise are nowhere near the forces that are necessary to get out of a chair. And yet over and over again, I see the use of the standard 2-pound ankle weight for these types of exercises in a variety of settings. And so, you know, we're conservative because we, above all else, do no harm principle always applies. But we're really trying to provide some evidence to shift from the conservative low intensity interventions that we're seeing across the country to promote higher intensity interventions, all based on the American College of Sports Medicine guidelines as well as the American Geriatric Society. And so our paradigm that we've been developing and building and growing really focuses on flipping the pyramid that I described on the left earlier upside down. So instead of having resistance training be the least used modality, we want it to be the foundational pillar of everything we do. We can do balance training with resistance training concurrently. We can do a lot of things that incorporate resistance training in functional activities and achieve the goal of overload in ways that we actually see muscle strength gains and muscle hypertrophy. And when someone doubles their strength, they're able to walk that much farther, which ultimately then translates to better cardiovascular conditioning down the road. But with not as much time consumed during an individual rehabilitation session, because the resistance training program that we have developed and been promoting doesn't take additional time. In fact, it allows you to be more efficient with the time that you do have available. So the idea is to work smarter and not harder. The basic premise is that in this case, more repetitions are not better. If you go to the gym or in the distant future when we're allowed to go back to the gym, and you watch individuals performing 15 repetitions of an exercise, unless they're training a endurance-based muscle, like scapular stabilizers or certain postural muscles that are really important in an endurance capacity, they should be doing fewer repetitions with higher weights. And so the premise behind all of what we do is that we're promoting 8 repetitions with the 9th to failure. We don't use the word failure with our patients, but what we're trying to do is see evidence that the individual is unable to perform that 9th repetition with proper form through the entire range of motion. And so 8 with the 9th to failure is what we're promoting. So our goal is to achieve muscle overload and provide a stronger and different stimulus every time. We objectively assess progression daily. So instead of a traditional approach of using a 1-rep max, where you measure the maximum amount of weight an individual can lift through the range of motion with a particular exercise, and then you dose at 80% of that, we're able to do 8 to failure without ever having to measure that 1 repetition max, if you're familiar with that terminology. And so every single session, every single exercise, we're able to look for failure and determine if we should progress it, as opposed to having to progress it on a weekly basis when we reassess that 1 repetition maximum. So let me show you what this looks like. This is a sit to stand activity. The individual is going to go up and down. The hardest part of this program is counting, making sure we remember to count consistently and hit that 8 with the 9th to failure.
4, 5, 6, 7, do 1 more, and then we make it a little harder. 8. Okay.
All right, so clearly that individual had no problems performing 8 repetitions. And so the goal on the next set is to make it harder. And so we increase the intensity by adding an ankle weight. And you see there's a transient loss of balance. And you can see that in the video. But that doesn't necessarily signal failure. And so we continue with the exercise. and look for signs of failure. And you can see the individual's getting tired.
Give them a try.
So she's trying. Now she's at 8, she's at 9. So she's struggling. And she's unable to perform that last repetition without assistance. So in that particular case, and in many of our functional activities, it's not always exactly 8, but it's as close to 8 as we can get where we see a really clear sign of failure, indicating that the intensity of that exercise is appropriate. I'm gonna play this video for you here.
Unfortunately, she had a fall last week.
I don't know, let me make sure you can hear it.
This is Louisa. Unfortunately, she had a fall last week. She hates that she had to miss her grandson's birthday party. Research shows that many patients like Louisa are discharged from inpatient facilities when they are independent with certain tasks, but are actually functioning below levels that ensure their safety in the community. This puts them at risk for further loss of function, rehospitalizations, and decreased participation in the things that matter to them. To provide the best care, to generate the best outcomes, and to save the healthcare system time and money, rehabilitation for older adults needs to focus on efficiently maximizing physical function. Louisa's therapist is focused on improving function through strength training. She has been trained in high-intensity rehabilitation by the Restore team at the University of Colorado. She reads Louisa's chart and screens her for safe participation. She asks about her goals and takes vitals as the session begins.
What's this for?
That's a weight vest. We'll use it to challenge your system enough to increase your muscle strength during activities we work on in therapy. These strength gains then translate into better function at home. Plus, we're getting you stronger, faster.
The therapist carefully assesses Louisa's performance as she begins each exercise. She makes sure that, no matter the activity, Louisa demonstrates signs of appropriate exercise dose every time. She carefully documents the details of her prescription, so Louisa can continue to make progress in each session that follows.
Isn't this too much for me? I just had a fall.
I understand this feels challenging, but it's actually how we'll get you strong enough to prevent falls in the future. You may feel a little tired afterward, but I promise I'm monitoring you, and you're safe. I think you'll be pleased with how much you didn't realize you could do.
Patients participating in high-intensity rehabilitation demonstrated improvements in a range of key metrics. In skilled nursing, we saw a clinically meaningful improvement in gait speed, a 3.5-day reduction in length of stay, and an average cost savings of over $1,500 per patient. In home health, we saw similar improvements in gait speed and a 6-fold reduction in rehospitalizations. These outcomes were all achieved without any decrease in therapist productivity. After participating in high-intensity therapy, Louisa has regained the strength and confidence to perform her daily tasks at home and to spend time with the people who really matter.
So it gives you kind of just another perspective, another glimpse, but I'm going to share with you in a little bit more detail the data that was briefly presented in that video, which I hope you could hear. It's hard when you can't see your audience to see if it's working. But I'm going to start with I'm going to talk about a variety of different settings and share with you data on the benefits of this high intensity approach. And the first one is home health. We've been looking at high intensity rehabilitation through the course of 2 parallel but different clinical trials assessing different aspects of high intensity therapy, including protein supplementation, care coordination, timing of visits, whether we front load visits versus spread them out over a period of time. And so we've had an extraordinary team that's been involved in both of these clinical trials, leading the charge and helping us assess the potential benefits of high intensity therapy in the home setting. And our early data suggested that even though our intervention was provided over 30 days, the first 8 visits over 30 days in the home setting, individuals with this SPPB that I mentioned earlier, this standardized physical performance battery, continue to improve past that 30-day time point. So the red indicates individuals that receive this high intensity care, and they continue to make gains from 30 to 60 days. even after we finished the intervention, which we attribute to kind of exceeding that threshold of independence, getting above that threshold of independence so that they were able to interact with their community and participate in more daily activities. Whereas individuals in the control group or usual care had a decline from 30 to 60 days, in many cases because they hadn't exceeded or reached that threshold for independence. When you look at the gait speed in the context of the data that I presented, you see that these individuals following hospitalization started at 0.4 meters per second. And they improved with the high intensity intervention to 0.8 meters per second by 60 days. So getting closer to that target of 1.0 meters per second. Whereas individuals in usual care still fell below that 0.6 meters per second threshold, which puts them in that red zone, which makes them at very high risk for rehospitalization. When we look at PACE, I mentioned earlier, we worked with innovAge, so all-inclusive care for the elderly. We used a similar approach where we looked at high-intensity intervention resistance training that I've described. And what we saw was that we saw a marked improvement in the SPPB. So the SPPB went from about a 5 up to about just less than an 8, which is a 3-point improvement. And the clinically meaningful threshold for improvement in SPPB is somewhere between 0.5 to 1.0. So we had triple the clinically meaningful improvement in SPPB outcomes. And when we look at gait speed, we see again, people started in innovAge at a little over 0.6 meters per second, and they got up above 0.8 meters per second. And so again, we saw a doubling of the clinically meaningful improvement that I mentioned earlier, which is that 0.1 meters per second. What's really important about all the studies that I'm describing are that, there were no adverse events related to high intensity intervention. So I'll describe that a little bit more in our skilled nursing facility care. But most recently, we've been, as many people have been forced to do, transition to tele approaches to intervention. And the safest approach to telerehabilitation in these medically complex older adults is to have them seated in a chair and doing exercises where they are not at risk for falls. But we have had the good fortune of having 2 grants recently funded to help us really translate some of these high intensity approaches into the telerehab environment. So these are the individuals that people don't want to be treating with telerehabilitation because they want to be by their side, making sure that they don't fall. And we're trying to design programs that are safe and that still allow for adequate challenge to increase physical function. So the first is an NIH-funded R01 with Christine Erlandson as the co-PI of that particular project and has led the charge very effectively in setting the stage for what we hope will be a successful outcome of telerehabilitation in individuals with COVID. So immediately following hospital discharge, enrolling these individuals in a telerehabilitation program to see whether we can speed up the course of recovery for many of these very deconditioned individuals. And then we also have the good fortune of a grant from the office, from the VA, from the Office of Connected Care with telerehabilitation for medically complex patients. So some with and without COVID, with Hilary Lum, Katie Nearing, and Lauren Abate as co-investigators, along with Michelle Rousey on that particular project, leading the charge to try and see, again, what can we do from a distance that doesn't diminish the dose of exercise that's necessary to achieve gains. And then finally, I'll describe our most recent completed clinical study where we have been looking at, this was recently published in October, physical function in skilled nursing facilities. And again, this is where we took individuals who had all sorts of risks for falls and were highly deconditioned from a prior hospital stay. And what we saw was an improvement in our short physical performance battery of 0.64 points. We saw a gait speed improvement of 0.13 meters per second, which is again, a clinically meaningful improvement in gait speed. We saw community discharge rates increase by 20%. And we saw a decrease in the skilled nursing facility length of stay of 3.5 days. And this was done in our Fitzsimmons State Vets Home. And I think it's really important to emphasize that we didn't give therapists any instructions. They are a phenomenal team over there, the rehab team. We didn't give them any instructions to decrease length of stay, but it was a byproduct of the improvements in physical function. So the fact that we saw improvements in physical function with a concurrent decrease in length of stay makes us wonder whether the changes in physical function would have been longer had we held the length of stay constant, which of course in real world clinical practice isn't a possibility. And the next steps for this particular area of research look promising in the form of a likely funded cluster randomized trial at nursing facilities across the country to demonstrate the feasibility and work on the implementation aspects of training individuals in this high intensity approach. And so what would, when we kind of provide a summary, what does overcoming these barriers look like? The barriers that I've just described. Oops, I'm sorry, I didn't mean to, really thinking about using evidence-based practice to increase and focus on therapeutic value in fewer visits is becoming the norm. We don't have as many visits in many of the settings that I described. Home health, skilled nursing, stays are getting shorter. And so really increasing the quality of the therapy that we're able to provide. Creating programs for strength retention post-discharge is another area that I think is going to be important. In other words, we need sustainability of intervention. We can't have this episodic care that results in kind of a revolving door of people coming back through our facilities, but really thinking about ways that we can promote sustainability of intervention. Providing ways to overcome this negative defensive medicine. So really providing evidence to support the fact that we should be getting people up and moving. We should be getting them stronger, and as opposed to having them sit in their chair or in their bed where it's safe. I talked about emphasizing that progressive strengthening, it should be done beyond kind of their prior level of function if they were hospitalized, because that's possibly one of the factors that led to their hospitalization. And then figuring out how to broadly translate some of the research that I've described into clinical practice. So how do we change practice on a larger scale? And so when we look back at the case that I presented, the individual that had a 0.9 meter per second gait speed that resulted in and came in to see you all and now has a 0.7 meters per second gait speed, that patient should have received education on gait speed and the importance as to how it links to decline in overall health status, and referred to outpatient physical therapy to improve that gait speed, improve muscle strength, and improve overall mobility. So again, that 0.9 to 0.7 was a clear indicator of something having changed. I'm going to wrap up by thanking a number of individuals who have been actively participating in much of the research that I've described in our future work moving forward. And we have a group called the PACRATS, which stands for Post-Acute Care Research and Team Science. And Carrie Levy has actually a conference grant, and of course conferences are temporarily on hold, but Carrie Levy and Hillary Lum and Christine Jones and Katie Nearing and others have been actively involved in redesigning kind of, instead of conference grant emphasis, but focusing more on consultations and other opportunities to continue to grow work in the area of post-acute care research. And so I mention this because if you're interested in post-acute care research and want to get connected to this group, certainly reach out to myself or Carrie Levy, and we can get you connected to the right people. I also want to thank individuals beyond just my core group, the Restore group over in the physical therapy program, that have been absolutely instrumental in helping with all of this work. It takes a village to do clinical research, especially when you're partnering with community facilities. It really is a group effort. And in particular, I mentioned the State Vets Home on campus and the leadership over there, and the team has been absolutely instrumental in helping facilitate much of that work, in addition to the work I described in home health settings and innovAge. Funding that has supported a variety of this work. And a huge thank you to my Restore team in the physical therapy program, which consists of faculty, research assistants, PhD students in the Rehab Science PhD program, postdoctoral fellows, and many of our DPT students who are actively engaged in our research. Certainly reach out if I can be of help in terms of answering questions. And it looks like, let's see, it looks like there's a couple of questions in the chat box here. Let's see. So one from Jeff. So Jeff Wallace, who has, again, been really instrumental in helping us at the State Vets Home, leading the charge with some of the work that we've been doing there. So Jeff says, while PDPM starts to realign therapy and reimbursement, are there any clear financial incentives in the new system to do higher intensity therapy? And that's a great question. So our vision was, when we first started this work in skilled nursing facilities, many of our facilities, it was a bit disheartening, said, no, we're not interested. It's going to add more workload to our therapists to train them in this high intensity approach. And we get paid on minutes of therapy. So there's less of an incentive for us to participate. But with PDPM, because of the reimbursement models, the faster we can get people better in terms of out of the facility, the better the payment structure. And so it's not identical, certainly, to what's happening in acute care hospitals, but some elements of increasing the speed of discharge works to our advantage, because if we can decrease the length of stay by 3.5 days in a skilled nursing facility and increase physical function and have people not at greater risk for rehospitalization, then ultimately the reimbursement is going to be better in those facilities. So our vision was to have our research eventually align with reimbursement, and it has. And we're fortunate that CMS changed the reimbursement models in skilled nursing facilities to help promote what we think is best practice. I think, let's see, if there are other questions, Carrie, I'm not sure. It looks like people can enter them in the chat box.
So there's a question in the chat box as well. Let's see. And I apologize. I know my microphone wasn't working very well, so hopefully people can hear this. And if they can't, I don't know if you have access to the chat box, Jen. But one question is whether you have operationalized routine gait assessment in the clinic. For example, is this something the medical assistant can do on the way to the room? And has there been pushback on additional time required when they're already busy?
Great question. So so obviously everyone's busy trying to see patients and and provide patient care efficiently. But if you set up a course where you have a clearly delineated 4-meter walkway is probably the most typical, and you have a MA collect blood pressure, height, weight, whatever typical assessments in your clinic you would expect, and then you have an individual just walk down the hall towards whatever room they're going to be in. You can set up the gait speed distances in a variety of places throughout the clinic. All the medical assistant needs is a stopwatch to collect the data, basically, or the health outcomes data of gait speed during a routine clinical visit. So what we've seen is it doesn't really add appreciably to the workflow in terms of time. It ideally is entered into the medical record in a discrete location so that it can be easily accessed, like blood pressure, on a return visit, to see what the change is over time. Like anything, it takes time to implement something of this nature, but it really hasn't been as big of a lift in the settings where my colleagues have started to implement this. We're in the early stages of doing so in the VA, and obviously with COVID, we had to pause on a lot of the in-person types of assessments like gait speed, but we hope to be able to go back to that later this year or 2021.
Thanks.
Are there other questions in the chat box, Carrie, that I'm not seeing other questions right now?
Check and see. I don't see any additional questions coming in here. And we're about at the end of the time here. So I guess if there are other questions, maybe people can reach out to you separately. But
absolutely.
Yeah, I just thank you so much, Jen. This was a wonderful, wonderful presentation, very timely and up to date, and we really appreciate your doing that. So
thank you all,
everybody, for participating, and please check your email for the link to the evaluation and take a couple minutes to fill that out. So thanks, everyone, and we'll see you on December 3rd.
Thanks, everyone.
Thanks, Jen.